hemolytic reaction is essentially saying that we have some incompatibility in these red blood cell antigens. Okay, and incompatibility is just referring to what we talked about. It's a situation where we have an antibody and we have an antigen on the red blood cell, leading to the destruction of that red blood cell. Okay, so that's essentially what I'm talking about with incompatibility. Now, if we did a red blood cell transfusion, right, that's going to be this top box. We're giving this top box to another patient. Okay, so that would be a red blood cell transfusion. Let's just say that I take this patient and I give this patient group B blood, right? So if I have a patient that's group A and I give them group B blood, I'm giving them the red blood cell, right? I'm giving them this box right here with the group B antigen on the surface. And this patient has anti-B antibodies. So this is going to be my donor. So the donor is giving group B blood, and the recipient is going to be group A. So the recipient's group A, the donor is group B. And so what we're talking about here with incompatibility is going to be destruction of the donor's red blood cell, right? It's these red blood cells that are being donated that are going to be marked for destruction by the recipient's preformed anti-B antibody. Okay, so that's if I did a red blood cell transfusion. Now let's say I did a transfusion of fresh frozen plasma. Let's say I do the same thing. Let's say I have a patient that's group A blood type, and I give this patient fresh frozen plasma from a group B type patient, right? So I'm going to give the plasma, which is this box here, right? I'm going to give the plasma to this group A patient. Okay, so I'm going to give them this plasma, and I have anti-A antibodies in that plasma that's going to target these A antigens and mark the recipient cell for destruction. So in this situation, the donor had the preformed antibodies, and the recipient's red blood cell, right, the host, those red blood cells were marked for destruction. So it's kind of flipped. In this situation, it's the recipient's red blood cells that are being marked for destruction in the setting of a fresh frozen plasma transfusion. Okay, and in all of these situations, this is a type 2 hypersensitivity. We have antibodies that are binding to the surface of the red blood cell to mark them for destruction. In a lot of these different reactions, the reaction could happen at different times. It can happen during the transfusion, it can happen after the transfusion, right? So it's variable. However, in board questions, there's always classic ways that things are presented. And this is not an exception. In acute hemolytic reaction, it's very classic that the reaction will happen during the transfusion. Okay, so there are going to be other types of type 2 hypersensitivity transfusion reactions, but this is the primary one that's going to happen during the transfusion. So as the transfusion is happening, these patients might present with pain at the IV site as they're getting the transfusion. They might start to have some jaundice, scleral icterus, right? These are all classic for bilirubin, particularly indirect bilirubin from the red blood cell breakdown. Okay, they can have chills, hemoglobinuria from the red blood cell breakdown, right? All that hemoglobin in the blood, that can potentially also cause kidney damage, right? And so you can see dark urine as a very classic presenting sign to indicate that these patients might be having an acute hemolytic reaction. And then if it's really severe, these patients might develop hypertension, tachycardia, right? This can be very serious. And for that reason, in general, the thing that you'll see as a recurring theme across all of these different transfusion reactions is you want to stop the transfusion, right? If you're in a situation, a patient starts to become symptomatic during transfusion, the first answer choice every time is going to be immediate cessation of that transfusion. And then obviously monitoring or treating that patient. A following step to that would be to investigate exactly what happened, right? And so that would include something like a direct Coombs test. So just to kind of build on this direct Coombs test, because we've talked about this in great detail, this is a particularly high yield thing to focus on when we're talking about hemolytic reactions. So let's just take a look here. So this first column here is going to be our donor. This is going to be our recipient. Now in these situations, let's just say that, like we said, we have a type O donor. No matter what type of antibodies are in the recipient's bloodstream, right? So let's just say that these blue ones are going to be anti-B antibodies. Okay, these will be anti-B, and then these red ones here will be anti-A. Okay, so we have anti-B and anti-A antibodies, okay? And not every patient's going to have, both of these, right? Some might have one or the other, some might not have any. But the point is, just for an extreme example, you can see that when I give type O blood, there's nothing for these antibodies to bind to. If I give type A blood, right, there's a possibility that this patient might have anti-A antigens, and the same is true for type B. They might have anti-B antigens. And if I have AB, if they have either one, they're going to get targeted, right? These are all the same things that we kind of talked about. But the point is, what I'm essentially doing with a Coombs test is I'm giving this patient anti-A or anti-B antibodies, okay? So this is the original antibody that we talked about, and I'm making another antibody to that, right? So I'm making another antibody to this, essentially, is what I'm trying to do. And I'm trying to get this thing to bind here to cause agglutination, okay? If that happens, that tells me that on the surface of these red blood cells, there are antibodies bound, okay? So if I have a positive direct Coombs test, that tells me that there's antibodies bound to the surface of the red blood cells. Which antibodies? Well, it depends. Did I give them anti-A or did I give them anti-B antibodies, if that makes sense, right? So I'm making an antibody against the antibody on the cell surface, and if that antibody is present on the cell surface, my anti-A antibody in this situation will bind, or if it's an anti-B antibody, it will bind, right? And it will bind, causing agglutination. And agglutination would be a positive test. And it tells you that this red blood cell is essentially marked for destruction. And you'll see that this is not the only hemolytic reaction that has a positive direct Coombs test. The delayed hemolytic reaction, which is a very similar mechanism, also presents the same way. It just takes a lot longer to get that presentation. You're not going to have a patient that's in the middle of a transfusion that has symptoms with a delayed hemolytic reaction, at least not in a classic board question. Okay, and then the diagnostics, you'll see a lot of these are just, going to be synonymous with red blood cell breakdown, hemolysis in particular. So an increase in your LDH, right? Your lactate dehydrogenase, bilirubin usually will be elevated, causing some of the jaundice. And then haptoglobin, when red blood cells are destroyed, and we have hemoglobin that enters the bloodstream, right? So we have red blood cell destroyed, we have hemoglobin that enters the bloodstream, right? This hemoglobin can then bind to haptoglobin. Okay, so this hemoglobin and haptoglobin will bind together, and what will happen is your levels of haptoglobin, because they're all getting bound up by hemoglobin, they'll come down. Okay, so the levels of haptoglobin will go down because they're getting bound up from all the hemoglobin that's kind of being released essentially from these red blood cells that are being destroyed. That's the general concept. These are essentially giving you some indication that there's red blood cell breakdown.